let's begin our session with Kitab Al-Fatih. Okay, all right, let's proceed.
So, Bismillah, Assalamualaikum, good evening everyone. So today we'll be covering the Haematology seminar. So our supervisor, Dr. Syed. So we have 5 topics. Nutritional anemia, which will be covered by me. Aplastic anemia, Thalassaemia, GCD and hemolytic anemia, and lastly ITP, idiopathic thrombocytopenic purpura. So let's proceed to nutritional anemia. So here is the outline of this seminar. So we'll be covering about the definition of the anemia, the classification, and also we'll be diving into nutritional anemia under microcytic hypochromic and also macrocytic morphology. So what is anemia? So according to WHO, anemia is defined as hemoglobin level below the normal range for that child of that age and gender. So here I included the hemoglobin and hematocrit normal range according to age group. So this one I got from the Nelson Essential, page 500 and 508. So if we refer to other sources, there'll be a different age group that is provided. So it doesn't matter. It doesn't matter much. So let's proceed. So the classification of anemia, we can either classify based on the etiology, the mechanism of the anemia, or the morphology of the anemia itself. So the classification of anemia can be divided into 3, which are impaired red cell production, which include red cell aplasia, for example, parvovirus B19 infection, aplastic anemia. And the other one is ineffective erythropoiesis, which may include iron or folic acid deficiency, or maybe anemia due to chronic disease and also chronic renal failure. So next is increased red cell destruction, which will be presented by next presenter under hemolytic anemia. So there are red cell membrane or enzyme disorder. For red cell membrane, we have hereditary spherocytosis. For enzyme disorder, we have G6PD. Under hemoglobinopathies, we have sickle cell and thalassaemia. And for immune, we have autoimmune hemolytic anemia. So lastly, we can classify under blood loss, which may include fetal-maternal bleeding, chronic gastrointestinal blood loss, for example, Meckel diverticulum, and lastly, inherited bleeding disorder like von Willebrand disease. So the other classification of anemia under morphology, so we can classify it into hypochromic microcytic anemia, which may be caused by iron deficiency anemia, iron deficiency, thalassaemia, and also anemia due to chronic disease. For normochromic normocytic type, it may be caused by chronic inflammatory disease or anemia due to chronic disease, recent blood loss, and also malignancy. And lastly, it can be classified into macrocytic anemia, which may be due to megaloblastic anemia, either vitamin B12 or folate deficiency, hypothyroidism, and lastly, marrow failure. So let's dive into the nutritional anemia itself. So under microcytic hypochromic morphology, we have iron deficiency anemia. So what are the etiologies for the iron deficiency anemia? There are 3: inadequate iron intake, malabsorption, and also blood loss. But we'll be focusing on inadequate iron intake. So it is common, inadequate iron intake is common in infants because additional iron is required for the increase in blood volume, for growth, and also to build up the child's iron store. So here I included the iron requirements during childhood. So to compare with the adults have 4 to 5 gram iron body stores, while the newborn have only 250 milligram, which can be divided into blood, inferrin, and hemosiderin. So the iron intake from diet can be quantified based on this picture, like at the bottom, the most bottom picture. You can see at the breast milk, there is 1.5 milligram per liter, in which 50% of the iron is absorbed, compared to the infant formula, the powder milk for baby. It has 5 to 9 milligram per liter, but only 10% is absorbed. And other like cow's milk and mixed diet, you can see there. So epidemiology of iron deficiency. So it is the most common cause of anemia in the world. The prevalence of iron deficiency worldwide is 9% in toddlers, 9 to 11% in adults and girls, while less than 1% in teenage boys. So iron deficiency anemia occur in about 1/3 of children who are iron deficient. It is seen that the breastfed infants have lower risk to develop iron deficiency anemia compared to bottle-fed infants. This is because of the amount of iron that can be absorbed through the milk compared to the bottle-fed. So the prevalence of iron deficiency anemia among adolescents in Malaysia is 17% in 2001 to 2000 to 2001, according to WHO statistics. So it is a study that has been conducted in Sabah, if I'm not mistaken.
Are you sure iron content is lower in is higher in breast milk as compared to formula?
No, I mean the amount of the iron that can be readily absorbed is much higher than the bottle fed. Yeah. Okay. Let's proceed. The pathogenesis of iron deficiency anemia. So there are pre-latent stage, latent stage, and also marked iron deficiency anemia. So in pre-latent stage, the iron stores will deplete, which can be marked in decline in serum ferritin and also absence of stainable iron in bone marrow. So in latent stage, there will be decrease in serum iron and rise in serum transferrin. And ultimately, when there is no iron, the capacity to synthesize hemoglobin, myoglobin, and other iron-containing protein is diminished. This will result in microcytic anemia. So the clinical features for patients with iron deficiency anemia. So most infants and children are asymptomatic until the hemoglobin drops below 60 to 70 gram per liter. Okay. So the clinical features that we may see are fatigueness, and also the young infants will feed more slowly than usual. So we can also look for pallor at the conjunctiva, tongue and palmar creases. Angular stomatitis, you can see at the bottom, top left picture at the mouth, the angular stomatitis, glossitis, the inflammation of the tongue, and also koilonychia, which is spoon nails. You can see at the picture at the top right. We can also observe for blue sclera. You can see at the picture at the bottom. And also the patient may come with pica, which is inappropriate eating of non-food materials. For example, like soil. When they are playing, they suddenly eat soil. So that is termed as pica. And lastly, there will be CNS abnormalities such as apathy, which is lack of emotion, irritability, and also poor concentration. So moving on to investigation. So in patient with iron deficiency anemia, we can look for the food blood count. There will be low hemoglobin and hematocrit, and also MCV and MCH. We can order for peripheral blood smear, which we may expect for hypochromic microcytic erythrocytes, the iron study will show low serum ferritin and serum iron. And lastly, we need to ensure that this diagnosis is differentiated with beta thalassemia and anemia of chronic disease. You can see at the table beside of this text. Yeah. We can see how to differentiate between iron deficiency anemia, thalassemia, and also anemia of chronic disease. So management for patient with iron deficiency anemia, there are three. First, we give nutritional counseling with advice on diet. We maintain the breastfeeding for the infant. We use iron fortified cereals and also iron supplementation. And second, we can give oral iron medication, which may include syrup FAC, ferrous ammonium citrate, and also or ferrous fumarate or sulfate tablet. And lastly, we can give blood transfusion, but it is usually not indicated unless there are signs of decompensation. So here are the dietary sources of iron. You can see for the high in iron, there are red meat, liver, kidney, and also oily fish. And you can see others. So moving on to megaloblastic anemia, which include vitamin B12 or cobalamin deficiency.
Wait. How do you differentiate again between IDA, thalassemia?
So we can look for serum iron for iron deficiency. So for iron deficiency, okay. Do I need to explain? No.
Yes, explain.
Okay. So
you cannot just expect, because these are questions that we always ask in exam.
All right.
That's why I ask.
Okay, I'll explain. So there are several tests that we can use to differentiate between iron deficiency anemia, thalassemia, and also anemia of chronic disease. So for serum iron, the iron deficiency anemia will have low serum iron, and also the chronic anemia of chronic disease will also have low serum iron. But for thalassemia, it will have normal serum iron. Next is the serum iron binding capacity. In IDA, the serum iron binding capacity is high, while in thalassemia is normal, and for anemia of chronic disease, there will be low or normal serum iron binding capacity. Next, for serum ferritin, we can expect that the IDA will have low serum ferritin, while thalassemia and anemia of chronic disease will have normal or high serum ferritin. So next, we have marrow iron stores. So this in IDA, marrow iron store will be low or absent because there's no storage of iron. But compared to thalassemia and anemia of chronic disease, there'll be normal or high storage of iron in marrow. And for marrow sideroblasts, in IDA, there'll be decreased or absent marrow sideroblasts. Compared to anemia of chronic disease and thalassemia, there'll be normal or increased marrow sideroblasts and others. Yes. There is test for hemoglobin A2 or F. In iron deficiency anemia, it will be normal, but in thalassemia, we can see high beta thalassemia or normal alpha thalassemia, but for anemia of chronic disease, they'll be normal. And lastly, the red blood cell distribution with the the anisopoikilocytosis. I don't remember the name of the test, but that's the description for the different sizes and shapes for the red blood cell. For IDA, they'll be high because of the deficiency of iron to make the red blood cell. But for thalassemia and anemia of chronic disease, they'll be normal.
Any calculation that you can do to differentiate between thalassemia and also IDA?
Thalassemia and IDA calculation.
Anything, if you do full blood count, then you can calculate something. Calculate one index. To differentiate between thalassemia and also iron deficiency anemia. This has come out in exam at least twice.
Wait, I look up for it.
Tak payah look up lah. So it's Menzer index. So Menzer index, Mentzer. So Menzer index, Menzer index. So you can calculate Menzer index. Now you can Google. After this, masing-masing semua Google Menzer index, because if I were to make the question, I will ask you what's the Menzer index. So you calculate from the RBC count. Dia ada bagi apa. So go back, back apa kan? So after this, read what is Menzer index. So RDW. Why is the difference between, kenapa difference in RDW kalau if you compare between thalassemia and also IgA? Because thalassemia has anisopoikilocytosis as well kan? Dia ada target cell, dia ada apa nama pencil cell tu kan? So why? What's the difference? What's the matter?
I'm not sure.
So RDW, RBC distribution width ni, RDW. If you do full blood count, you'll see one of the indices is actually RDW. You'll see hemoglobin, RBC count, WBC, platelet, and among those is you'll see RDW. RDW, it may come in unit or in percentage. So the issue is RDW and Menzer index both actually shows the degree of anisopoikilocytosis. Maknanya the degree of distribution in terms of different sizes and shapes of the RBC. So in thalassemia there is anisopoikilocytosis. Sebabnya depends on the hemoglobin, isn't it? Depends on the building material, the globin and so on so forth. So bila ada dia akan, so dia different sizes. Sama juga dengan IDA. Bila IDA, the difference in sizes of RBC will be more marked as compared to thalassemia. Sebabnya apa? Sebab your RBC, your heme, your iron content will depend on the current iron level in your body at that particular time. Contohnya, bila at that particular time you baru lepas makan, for example, kan? So at that particular time you punya iron storage shoot up, kan? So masa tu RBC yang create yang made masa tu, dia akan size dia is a bit bigger. When you have less iron storage at that particular time, you punya RBC dia akan more hypochromic microcytic. They can smaller. So that's why you can see huge difference in terms of sizes of the RBC. Huge anisopoikilocytosis. So RDW akan high, more than 16. Menzer index pun sama. Menzer index is 13. So Menzer index will be more than 13. So these are all indicators of difference in terms of shapes and size of the RBC. Okay, all right, proceed.
Okay, thank you, Doctor. So let's proceed to megaloblastic anemia. So the etiology of megaloblastic anemia, there are two. First is folate deficiency, and the second one is vitamin B12 deficiency. So the deficiency of these vitamins, for folate, vitamin B9. So both of these play important role in DNA synthesis. So without these two, the DNA synthesis is impaired because of the inadequate amounts of metabolically active folate derivatives necessary for DNA-based synthesis, which will affect the hematopoiesis. So moving on to epidemiology. So the prevalence of megaloblastic anemia in childhood has not been established. The dietary vitamin B12 deficiency is a serious problem in India, Mexico, Central America, South America, and some areas of Africa. So these are developing countries. So the megaloblastic anemia is more common in developing countries because of malnutrition. So pathogenesis of megaloblastic anemia. So when there is depleted cobalamin or vitamin B12 or folate, vitamin B9, there will be impairment of DNA synthesis. So specifically, it will delay in nuclear maturation, and this will result in ineffective erythropoiesis secondary to intramedullary apoptosis of hematopoietic cell precursors. So here I include the amino acid metabolism pathway. You can see folate plays important role in producing tetrahydrofolate for DNA synthesis, and for B12 it converts homocysteine to methionine, which will further use for methylation of proteins and DNA. So the clinical features, first for vitamin B12 deficiency. So we can look for signs and symptoms of anemia, lethargy, fatigue, and pallor. And we can also look for vitiligo, which is the pigmentation of the skin. You can see at the bottom picture. And also glossitis, the inflammation of the tongue. So the tongue looks smooth and red and inflamed. Next, we can look for CNS symptoms like posterior column signs, which includes peripheral neuropathy or paresthesia, which is the numbness or tingling or burning sensation of the extremities, and also loss of vibratory sensation and proprioception, and there can be dementia and ataxia. So for folate deficiency, the clinical features are not specific, but the onset is insidious. We can also look for the sign symptom of anemia, lethargy, fatigue, and pallor, and also there will be glossitis, the inflammation of the tongue. So investigation for megaloblastic anemia, we can look for full blood count. There will be low hemoglobin, but there will be high MCV, and the MCH may be normal. For peripheral blood smear, you can look for microcytic erythrocytes. They may be teardrop cell and also hypersegmented neutrophils. You can see the picture there, the teardrop cell and hypersegmented neutrophil. Other than that, you can also look for serum B12 or folate level, which we expect it to be low. And lastly, you can do bone marrow aspiration. There will be markedly hypercellular, and the megaloblastic erythroid progenitors will present with immature nuclei, and there will be delicate, finely reticulated nuclear chromatin, which indicates nuclear immaturity. So management for patient with megaloblastic anemia, either way we can give, if the patient have vitamin B12, we give vitamin B12 deficiency, we give supplements, but for the folate deficiency, we give folate supplements. So here are the natural sources, the diets for the vitamin B12 and folate. I think that's all. So any questions?
Any question? Clear? Faham lah ke? Ketidur lah ke?
Ya, betul.
Okay lah, proceed.
Okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Amina Abdulrahman. I'll be continuing the second presentation for this seminar with the topic aplastic anemia. Next. Right. So aplastic anemia is a rare but serious form of bone marrow failure and it's characterized by peripheral blood pancytopenia due to bone marrow hypoplasia. So note that the name is aplastic anemia. However, you would also see leukopenia and thrombocytopenia also. Okay, next. Okay, so all right. So aplastic anemia is a rare disorder. So the overall incidence is low, and in Western countries, it's about two to five cases per million persons per year, but it's 2 or 3 times more common in Asia. There's no racial predisposition. Males and females are almost equally affected, and it can occur in all age groups. However, in acquired cases, it's more common in around in the age range of 15 to 25 years. And there's also another small peak at about 65 to 70 years. In cases where it's congenital due to inherited causes, then the usual age of presentation is about 5 to 10 years. All right, next. Okay, so aplastic anemia is usually in 80% of the cases, it's acquired, and in 60% of that, it's idiopathic, meaning that they cannot specify any particular cause. Other times, it could be due to infections such as viral infections like Epstein-Barr virus, HIV, and so on. It could be also due to exposure to ionizing radiation and to certain drugs such as these listed here. Toxins and chemicals can also lead to aplastic anemia. In some cases, before the last slide, please. The previous slide. Right. So in some cases, the aplastic anemia can be due to inherited causes. So no, the slide after that. Okay. Right. So this occurs in like 25% of cases in children and in about 10% of cases in adults. So here there are certain genetic disorders which eventually can develop into aplastic anemia. So the top 3 common ones are Fanconi anemia, Schwarzman syndrome, dyskeratosis congenita. So these cases cause aplastic anemia. So these disorders are known by their specific names. That's why when you see the term aplastic anemia mentioned, they always say it as acquired aplastic anemia, because if they're referring to the inherited causes, they would name it by its own by respective name. All right, next. So all of these disorders are rare, but among them, the most common genetic disorder associated with aplastic anemia is Fanconi anemia. It's a familial disorder which is inherited in an autosomal recessive pattern, and it's due to a defect in genes coding for DNA repair. So apart from bone marrow failure and predisposition to malignancies, it is characterized by certain physical abnormalities, like those listed here. There's more, okay, next slide. Okay, so this table shows the different genetic disorders that can cause aplastic anemia. And apart from symptoms of pancytopenia, each of these disorders have certain characteristic physical stigmata, which you can recognize them by. So you can read them later. They are listed here, okay? All right, next. Okay, moving on to the pathogenesis. So the primary defect in aplastic anemia is caused by a loss of hematopoietic stem cells. So as mentioned in the introduction, right, so usually aplastic anemia is due to acquired causes, and in this case, the pathogenesis is immune mediated. So exposure to an environmental trigger, such as viruses or drugs, can can alter the immunological appearance of the stem cells, causing it to express non-self antigens, and this makes it a target for autoimmune suppression or destruction by T cell lymphocytes. Right, so this is the most common pathogenesis, immune mediated. However, in other cases, such as when there is an exposure to radiation or to chemical toxins, it can cause a direct cytotoxic damage on the hematopoietic stem cells. Apart from this, another mechanism is when there are when the cause is a genetic disorder. So the pathogenesis is according to the individual gene mutation, which will lead to the loss of hematopoietic stem cells. But for example, in Fanconi anemia, like I explained before, there is a impaired DNA repair mechanism in all cells, including hematopoietic cells. So this can lead to premature death of the hematopoietic stem cells. So when there is a loss of the hematopoietic stem cells, this will eventually, after a certain time, when the stem cells cannot balance between self-renewal and differentiation, then it will lead to symptoms, it will lead to bone marrow failure. Next slide. Okay, so the clinical manifestations in aplastic anemia are related to the signs and symptoms of bone marrow failure, which manifests as pancytopenia. So you would expect signs and symptoms of thrombocytopenia, leukopenia, and anemia. The most common presentation is usually due to fatigue, shortness of breath, or bleeding and bruising tendencies, or a history of recurrent infections. Okay, next. Okay, you can check this out later. Next. Right. So in physical examination also, you would be looking for signs of pancytopenia, that is signs of anemia, thrombocytopenia, and signs of infection is usually not apparent during diagnosis, but yeah, the patient can be having fever or they can present with a history of recurrent infections. So apart from this, especially in children presenting with aplastic anemia with pancytopenia, you need to look for the physical stigmata that was listed down in the table before, which will indicate the presence of an inherited bone marrow failure syndrome. Another important characteristic of aplastic anemia is that on physical examination, you would not find any organomegaly. So that would be no lymph node enlargement or liver or spleen enlargement. So in the case that a patient presenting with pancytopenia has these symptoms, you would want to consider some other differentials. Next, for example, these like paroxysmal nocturnal hemoglobinuria or myelodysplastic syndromes or bone marrow infiltration by hematologic or non-hematologic abnormalities. And also certain infections can cause transient or permanent suppression of bone marrow function. Next. All right, so if you notice from the clinical manifestations, aplastic anemia is most definitely not a clinical diagnosis, so you need to do further investigations. so one of the main laboratory studies that you can do is full blood count, complete blood count with reticulocyte count. In that, you would expect reduced values. So these three values here, if two values out of these three are present, then this indicates pancytopenia. And you'd also expect a low reticulocyte count because of defective erythropoiesis. And yeah, the degree of cytopenia will correlate with the severity of aplastic anemia, and the severity will determine the management later on, as you'll see. Okay, another important test that we need to do is the peripheral blood smear. In the peripheral blood smear, it's usually described as a boring blood film, meaning that, okay, so this is the normal one, this is abnormal. So in the blood film, you notice that there is a reduction in numbers, but there is no morphological abnormalities, right? Then, though the anemia can sometimes be of a microcytic type, but there's no anisopoikilocytosis or any other morphologic abnormalities in aplastic anemia. Next. Okay, so in a patient presenting with signs and symptoms of anemia, who does not have organomegaly or any lymphadenopathy, and the peripheral blood smear shows these results, that is pancytopenia, reduced red cell density, and normocytic normochromic anemia, then it's sufficient. These criteria are sufficient to make a provisional diagnosis of aplastic anemia. However, yeah, so in any patient where these criteria are fulfilled, they need to do bone marrow studies, because this is the only way to definitely diagnose aplastic anemia. Next. Right. So in bone marrow studies, so you should do both bone marrow aspirate and biopsy, and you'd expect to find a hypocellular marrow, because this is like the key feature of aplastic anemia, and there'd be a decrease in all the elements in the erythrocyte and precursors and in the megakaryocytes. There'd be a decrease in all of them, and also the marrow space will be replaced by fat cells and stroma. So yeah, so this is the, yeah, I forgot to label it, I'm sorry. So this is the normal, this is the normal bone marrow biopsy picture. So here you can see that there are fat cells, but most of it have, there are hematopoietic stem cells as well. While here, most of it is just adipose tissue. And yeah, you can also see lymphocytes, plasma cells, and macrophages. So the biopsy is more accurate than the bone marrow aspirate, because sometimes in the bone marrow aspirate, you may mistakenly see places where there is hypercellularity, just small pockets of hypercellularity, but actually the overall, the bone marrow is hypocellular. So that's why you need to do a biopsy, because the assessment of cellularity is more accurate. So when is it called hypercellular is if there is less than hypocellular, if that's less than 30% cellularity in patients who are under 60 years old. And also it's in aplastic anemia, you would have to make sure that there's no infiltration by any malignant cells or any fibrosis, because this means that because these lead to other differentials. Okay, next. Right, so these are additional tests that you can do to exclude other causes of pancytopenia. You can read them later. Next. Okay, So the management for aplastic anemia is depending on the severity of the disease. Next. Next. Yeah. So in this picture, you can see the values of the blood cell count, which will help you classify the disease according to severity. So in non-severe aplastic anemia, previous slide, sorry. In non-severe, no, the last slide. Yeah, in non-severe aplastic anemia, the specific therapy is not needed. So supportive therapy is usually enough. Supportive therapy. Okay, so before that, if you have to identify and eliminate underlying causes, but in the case of aplastic anemia, this is very rare because most of the cases are idiopathic. So yeah, so the supportive therapy includes blood transfusion for the anemia and also platelet transfusion for thrombocytopenia and any prophylactic antibiotics for the leukopenia. Okay, so in patients with severe and very severe aplastic anemia, which according to the blood cell count values, it's considered a hematologic emergency, so they need immediate treatment. And the only curative treatment for aplastic anemia is bone marrow transplant. And apart from bone marrow transplant, you can also do immunosuppression treatment in patients where it's obvious that the disease is immune mediated. And immunosuppression therapy is usually combined with bone marrow stimulating agents also. Uh, all right, next. Yeah, next. Okay, so the complications of aplastic anemia is usually due to prolonged pancytopenia. So, for example, the thrombocytopenia can lead to hemorrhage, and the neutropenia can cause serious bacterial infections, and eventually can also make the patient more susceptible to having invasive fungal infections. There are also complications that can happen due to the treatment because for example, in non-severe aplastic anemia, the treatment is just symptomatic. So the patient might need to take frequent blood transfusions, which can lead to transfusional iron overload. So yeah, that's one of the complications. And in bone marrow transplant, they also have complications like graft-versus-host disease and graft failure. All right, next. Okay. So as I mentioned, aplastic anemia is a serious disorder. So it's not like self-limiting, and spontaneous recovery is rare. So if it's left untreated, then in cases of severe disease, the overall mortality rate is about 50% within 6 months and 75% overall. So it has a high mortality rate if it's untreated. And in infection and hemorrhage are the major causes of morbidity and mortality. In children who have acquired severe aplastic anemia, they show good response to marrow transplantation and immunosuppression. So they can, yeah, it helps. It has a good prognosis if they receive treatment soon. All right, next. Okay, these are my references, and thank you. Is there any questions?
Any questions? I think this one is quite straightforward. Aplastic anemia should be quite easy. Any questions to the presenter? Clear? Semua? We can ask aplastic anemia in exam. Boleh jawab? Itulah keras semua.
InsyaAllah itu.
Confident. Fine. Tak apa. Okay, proceed. Next. How many presenters today?
5, Doctor.
5. Okay, alright. Okay, proceed.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Afiq bin Nasir, and today I'll be presenting about thalassemia. So let's begin. Here are my table of contents. Okay.
Okay,
According
before you begin, I just want to say, thalassemia is among the few diseases that we expect it to integrate. So thalassemia, asthma, those are among the diseases that we expect you to know in great detail. Okay.
shall I continue, Doctor?
Yes, proceed.
Okay. According to Nelson Pediatrics textbook, 20th edition, thalassemia refers to a group of genetic disorders of globin chain production in which there is an imbalance between the alpha globin and beta globin chain production. So thalassemia is a hemoglobinopathy disease, which is a genetic inheritance disease. Okay, before we dive even deeper, I think we should take a look on the normal types of adult hemoglobin first. So in a normal RBC, there are three major types of hemoglobin, namely hemoglobin A, hemoglobin A2, and hemoglobin F. Hemoglobin A contains alpha and beta globin chain, whereas hemoglobin A2 contains alpha and delta, whereas hemoglobin F contains alpha and gamma. And as you could see here, this is the composition of the hemoglobins in the RBC. Hemoglobin A being the most. You can see in thalassemia patients there are differences between the composition of hemoglobins, different types of hemoglobin in the thalassemia. Thalassemia is a disorder of inheritance. It is an autosomal recessive disorder. So in thalassemia patient that we have one thalassemia allele, heterozygous, the patient will be a carrier, which is asymptomatic. Whereas if the patient has two thalassemia alleles, the patient will be homozygous. Patient will be thalassemia major or intermediate. Screening is very important before marriage to prevent the offspring being a thalassemia major patient. Okay, moving on to the epidemiology of thalassemia in Malaysia. According to the Malaysian Thalassemia Registrar in 2018, there are 7,984 registered thalassemia patients in Malaysia. Thalassemia is the most common genetic disorder in Malaysia. And from the 7,984 patients, 63.95% of them are Malays, followed by Chinese, 11.75%. And then we have the Kadazan Dusuns from Sabah. And if we compare the gender, it shows equal distribution. And if we compare the different types of thalassemia, thalassemia HBE or beta thalassemia is the most common type of thalassemia in Malaysia, followed by thalassemia major, HBH disease, and beta thalassemia intermediate. So here's the graph showing the thalassemia, representing the thalassemia patients in Malaysia. Moving on to the beta thalassemia. Beta thalassemia is characterized by the severe reduction in the production of in beta globin, which shows the decrease in HbA, because when there is production of beta globin over here, so eventually will be decrease of hemoglobin A. It is duly because of there is point mutation at chromosome 11 of the beta globin genes. So here is the genotype of the beta thalassemia. There is beta normal, which is normal, beta plus, which shows small amount of beta globin chain produced, and there is beta naught. And here is the phenotype of the patient. If there is B plus B or B naught beta, the patient will be thalassemia minor. In thalassemia intermedia, the genotype will be B plus or beta naught beta. And in thalassemia major, there is total absence of beta globin chain production, which is the genotype will be B naught and B naught. Okay, this is the pathogenesis of beta thalassemia. Like I mentioned earlier, there will be point mutation at chromosome 11. And because of this, there will be excess of alpha globin chain. Due to excess of alpha globin chain, and there will be not enough beta globin chain to bind to the alpha globin, causing a difference between the ratio of the alpha globin chain and the beta globin chain. The ratio will be 2 to 1. So when there is excess of the alpha globin, the alpha globin is actually unstable, and this will cause a precipitation of alpha globin chain in the red blood cell, causing membrane damage of the red blood cell. And this will cause destruction of the red blood cell in the medulla in the bone marrow, causing ineffective erythropoiesis. However, there are some mature red blood cells produced that will also contain alpha globin chain, uh, and this will cause abnormal membrane also of the RBC. And the abnormal membrane of the RBC will cause extravascular hemolysis when the RBCs passes through um, at a microcirculation, such as in the spleen. In beta thalassemia patient, a major patient, anemia will be more apparent when the patient uh, age is about 6 months of life. This is partly because of the hemoglobin switching from the gamma chain to the beta chain. Because as we all know that in the thalassemia patient, there will be no beta chain. So just there will be no switch. There will be switching. Just remain to gamma. Here's the pathogenesis of beta thalassemia minor. I'm not gonna explain everything because it's actually just more similar. The only difference is in beta thalassemia minor there is mild microcytic anemia, whereas in beta thalassemia major, the anemia will be more severe. So beta thalassemia is classified into beta thalassemia trait, beta thalassemia intermedia, and thalassemia major. So there are, based on the different types of beta thalassemia, we could see different laboratory features, such as in the hemoglobin, MCH, and then MCV, and the HB analysis. So in the beta thalassemia trait, the anemia would not be quite apparent because just a small reduction of the hemoglobin. And if we see in the thalassemia intermedia, the anemia will be more apparent because of the reduction of the hemoglobin, 7 to 9 gram per deciliter. And then there is a difference in the hemoglobin analysis, more hemoglobin F. And in thalassemia major, the anemia will be more severe. The hemoglobin level could reach below 5, and the MCH and MCV will be totally low. Moving on to alpha thalassemia. Okay, alpha thalassemia is characterized by the absence or reduced of synthesis of alpha globin chain. It is because of the deletion of the alpha globin on chromosome 16. In a normal person, there are 4 copies of alpha globin gene, 2 on each loci. So in alpha thalassemia, there will be a deletion of 1 or 2 or 3 or even 4 alpha gene deletion. So in just one deletion of alpha globin gene, the patient will present as silent carrier, which is asymptomatic and usually not found in routine testing. In the 2 deletions of alpha thalassemia, alpha globin gene, the patient will present as thalassemia minor. Okay, and next, if there is 3 deletion of alpha globin gene, the patient will present as hemoglobin H disease. And if there is total deletion of the alpha globin gene, patient will present as hemoglobin Bart's disease, or also known as hydrops fetalis, which is incompatible with life. Here is the pathogenesis of alpha thalassemia. I'm just going to explain about the HBH disease and the hydrops fetalis. So here in HBH disease, there are 3 deletions of alpha globin gene. This will cause imbalance between the alpha globin chain and the beta globin chain, and this will cause excess beta globins, producing a hemoglobin that contains a tetramer of beta globin chain, which is the hemoglobin H. And in the electrophoresis of hemoglobin, it will show there is presence of hemoglobin H disease. In HBH disease, it is the patient will have moderate anemia with microcytic hypochromic RBC. Okay, in hydrops fetalis, there is no production of alpha globin chain. This will cause production of uh, hemoglobin buds, which has 4 tetramer of gamma globin chain, and HB buds is extremely has a high affinity towards oxygen. So when the fetus takes oxygen from the mother, so because of the HB buds has a high affinity towards oxygen, the oxygen in the hemoglobin cannot be released to the fetal tissue, causing the fetus to experience tissue hypoxia, and this will cause a major organ failure in the fetus, and the patient will present with hydrops fetalis. Okay, this is a picture of hydrops fetalis fetus. Uh,
So what is hydrocephalus?
okay, hydrops fetalis is characterized with swollen liver and severe abdominal swelling, and the patient will die in the uterus of the mother. So there will be a severe edema of the organs of the patient. Okay, this is the classification of alpha thalassemia. So it's divided into silent carrier alpha thalassemia, alpha thalassemia trait, HPH disease.
Okay, wait.
Yeah.
Let me say something.
Yes, doctor.
So wait, presenter. Let me say something. Is hydrocephalus is basically heart failure in fetus. Hydrocephalus is basically heart failure in fetus. It's not incompatible with babies with hydrop that can survive. There may be that with hydrop that can survive. Basically, you'll find at least hydropic. You may have ascites, you may have pleural, you may have so at least two that are hydropic. Okay, alright, proceed.
Okay, moving on to the classification of alpha thalassemia. Okay, so alpha thalassemia is divided into silent carrier, alpha thalassemia trait, HBH disease, and HB Bart's disease. Okay, so in the silent carrier, there is normal hemoglobin level. So everything appears normal because silent carrier is asymptomatic. So in alpha thalassemia trait, there is a mild anemia, and in HPH disease, there will be a presence of HPH inclusion. So in the electrophoresis, we might come up with hemoglobin H. And in hydrops fetalis, the fetus will die in the uterus, and the HB analysis will show mainly HB Barts. Moving on to the clinical features. So this is a case of thalassemia that I found. Uh, Showing thalassemia. So Carl is a 6-month-old male who was born at 39 weeks via an elective C-section, admitted to pediatric emergency. So a history of presenting illness show that there is increasing irritability with difficulty feeding recently. Been gaining weight and his glucose being normal, but he is smaller than two of his siblings. So from here we could say that the patient has increasing irritability he was also smaller than his two siblings, could be suggestive of uh, failure to thrive or because of the anemia. From here, we could ask for the history of the family history. Does the parents of this patient carriers of thalassemia? So in the physical examination, uh, we could find that there is hypotension, tachycardia, and there is also slight paleness, pallor. And in the cardiovascular examination, there is systolic murmur and hyperdynamic precordium. Okay, hyperdynamic precordium is meant by the uh, abnormal more movement of the precordium, which is the chest. And there is unremarkable in abdominal examination, there is mild splenomegaly. So we could see based on from the history and the physical examination, we could say that we could find that there is patient is fatigue, dyspnea, and irritability. So from here, it is actually symptoms of anemia, could be suggestive of thalassemia. And from the physical examination, we could find the patient failure to thrive from the uh, developmental examination, and there is pallor and hepatosplenomegaly. And could later findings could show there is bone deformities such as frontal bossing, skull bossing, and long bone deformities. So anemia is because in thalassemia patient is because of ineffective erythropoiesis and hemolysis. Some signs of anemia include conjunctival pallor, shortness of breath, tachycardia, and lightheadedness. Okay, a patient could also present with jaundice because of the hemolysis in the extravascular hemolysis. And jaundice is more prevalent in the beta thalassemia major patients. And there is also could find evidence of splenomegaly and hepatomegaly. This is because of the extramedullary hemopoiesis, because of the bone marrow not okay. So and also it also can be caused by hyperfunction due to extravascular hemolysis or even from the iron overload from transfusion, blood transfusion. Okay, the next is the thalassemic phases, or also known as chipmunk phases. In thalassemia patients in older children, we could find that there is frontal bossing and enlargement of the maxilla, and because of the bone marrow expansion. And yes, doctor.
No, I was trying to say, nowadays we try to not use all these animal name for certain features, like the chipmunk faces, even for Down syndrome, the simian single palmar crease. So we try not to use all those animal link name to certain features, because I think it doesn't sound politically correct. Even macam Down syndrome punya Mongolian slant something. So we don't use those type of terms anymore lah.
Okay, doctor. So we just call them thalassemic phases.
Yes, call it as what it is.
Okay. Okay. So
It's not wrong. It's just that it's not polite. It's not politically correct for us to use those terms now.
okay. So we just use the thalassemic phases because for ethical reasons. Okay. So from the skull X-ray, we could see that there is hair on end appearance on the skull X-ray because of the high activity of the bone marrow. Other clinical features might show signs of infection because of the anemia, splenectomy, iron overload, or even iron chelation intake, and also liver disease and osteoporosis, and even hepatocellular carcinoma because of iron overload. Okay, differential diagnosis of thalassemia. So the main DDX of thalassemia is iron deficiency anemia, which shows hypochromic microcytic anemia. So the previous presenter, Abdullah Hakim, has already explained about this. So I think I should just skip. Next is the investigation for thalassemia. So in the full blood picture and the full blood count, the patient will present with hypochromic microcytic red blood cells, which shows moderate to severe anisopoikilocytosis. And there will be nucleated red blood cells as shown here in the slide. And in the full blood count, there will be a high amount of red blood cell with low reticulocyte, and the hemoglobin will be low. And hemoglobin, MCV, and MCH will be low. So in hemoglobin studies, there are two hemoglobin studies. Firstly, high performance liquid chromatography and hemoglobin electrophoresis. So here we could see this is the hemoglobin electrophoresis, and this is the high performance liquid chromatography. So from these hemoglobin studies, we could diagnose whether the patient has thalassemia. So from the hemoglobin electrophoresis, we could find the composition of the different types of hemoglobin in the patient. So we take here beta thalassemia major as the example. So from the hemoglobin electrophoresis, we could see here that there is no hemoglobin A present because of the no production of the beta globin chain. This is the other investigations that we do. Liver function test shows hyperbilirubinemia because of the hemolysis. Yes. And also in DNA analysis, we do to confirm we do this during genetic counseling to detect during screening. So before the marriage, to detect whether the couple is a carrier of thalassemia or not. So here's the other findings, also other investigations, also pain radiograph to check for the for thalassemia feces, and HLA typing if we want to do bone marrow transplantation. Okay, next is the management. Okay, the first management for thalassemia, particularly in beta thalassemia major, is blood transfusion. So we do blood transfusion when there is emergency, where when the patient appears very anemic. So we do the blood transfusion without the confirmatory diagnosis of thalassemia. But however, we must do blood investigation first to determine the blood type of the patient first. And we do for thalassemia major if the hemoglobin is below 7. And we also do blood transfusion sometimes in thalassemia media patient if the hemoglobin falls below 8. Uh, okay. Based from the blood transfusion, thalassemia is divided into two: thalassemia dependent, transfusion dependent thalassemia, and non-transfusion dependent thalassemia. So transfusion dependent thalassemia is also known as beta thalassemia major. So in beta thalassemia major patient, the patient requires lifelong blood transfusion, whereas in other types of thalassemia requires just may have needs episodic, just not regular blood transfusions. They only require blood transfusion when there is shows symptoms of anemia. There are several complications of iron overload, mainly from the endocrine system, growth retardation, hypoparathyroidism, and pubertal delay. And there is also cardiac complications such as arrhythmias, cardiac failure, pericarditis, and patient can also come with liver cirrhosis. Okay, to prevent from
What is the cause of those complications?
Sorry?
What the cause of all those complications that you have just said? You
Iron
mentioned
overload.
some complications, isn't it?
Yes.
Yeah. What happened? What happened? So iron overload, ada banyak iron in the blood. So then what happened?
Um,
Position lah. So
because
iron
dia iron
deposition on the
deposition.
endocrine. Iron deposition. So sometimes, for example, you need to do MRI. You need to do not just any MRI. If you want to do MRI brain, for example, to look at the pituitary, whether there's any deposition of iron on the pituitary. You cannot just do any MRI. You need to do specific MRI T2 star. T2 star. So specific MRI can see whether there's any iron deposition or not. Not all MRI machine can actually. So you need to do specific MRI T2 star to look at iron deposition in the liver, in the cardiac, and also in the brain. Okay, alright.
Okay, to prevent from the iron overload complication, we do patient must do iron chelation therapy with blood transfusion. So there are 3 approved iron chelators based on Malaysian Pediatrics Protocol. Firstly, there is Desferol, or known as desferrioxamine, desfeprone, and deferoxyrox. There are certain times that that a splenectomy should be done when there is evidence of hypersplenism and also when there is high blood consumption. And before splenectomy, patient must have pneumococcal and Haemophilus influenza B vaccinations for 4 to 6 weeks prior to splenectomy. And
Why this two?
Because when the spleen is removed, so the patient will have low immunity.
Yelah, why pneumococcal, why Haemophilus influenza, what type of organism? Encapsulated organism.
Encapsulated.
Because all these encapsulated organism, Streptococcus pneumonia, Haemophilus influenza, this encapsulated organism, they are killed in the spleen. Some other bacteria you can kill in your lymph nodes, you can kill by other methods, but this encapsulated organism, you need your spleen to actually for you to kill them off. So encapsulated organism. Okay, proceed.
Okay. So after splenectomy, patient will have to undergo penicillin prophylaxis for life, and if there is thrombocytosis, the patient must take low dose aspirin. And this is the non-pharmacological management. So the patient must have drink tea to decrease the intestinal iron absorption, and the patient must avoid iron-rich food such as red meat. And the patient must also take oral folate and low-dose vitamin C to help in the iron excretion. And if bone marrow transplantation can be done when there is a HLA compatible sibling marrow donor, and if there is unrelated donor, it is said to have a higher morbidity, mortality, and even higher rejection rates. Okay, the prognosis of thalassemia depends on the different types of thalassemia. So in beta thalassemia major patients, the patient requires a lifelong blood transfusion, whereas in the hydroxyspatalis, it will cause intrauterine death. And yes, for thalassemia intermedia and the other non-diffusion blood transfusion dependent thalassemia requires not routine, requires blood transfusion sometimes. Okay, here this is my references. Okay, any questions?
Okay, as I have said, thalassemia is among the disease that you need to know in great detail how you manage thalassemia, what are the features of thalassemia, how to diagnose thalassemia. Thalassemia are cases that we expect you to know in great detail. You won't see thalassemia cases in the ward because usually they are in the first. You won't see thalassemia cases in suspect. They will be in HTAA. So in this period of PKP, it's not going to be easy for you to meet this type of patient. Because in suspect we don't have, they are only in HTAA, and even in HTAA they won't be in the wards, they will be in the daycare if they come. That's one thing. The second thing is uh, one thing that I didn't notice you mentioned is about hypertransfusion regimen, because now we don't transfuse. With hypertransfusion regime, we aim for higher level of hemoglobin, even in beta thalassemia major. So we aim level of 12 usually. So we transfuse very frequently. With hypertransfusion of the hypertransfusion regime, anymore is typical frontal bossy and all those keywords.
Sorry, doctor, we can't hear you.
Anymore. Liver as well. Am I here? Am I better now?
No, your voice isn't too clear, doctor.
Hello? Boleh tak?
Yes. Boleh dengar, doctor.
So, dekat mana yang hilang tadi? Where did I lose?
Almost everything.
Dia awal, terdengar? Alamak, okay. Okay. Kita notice the presentation is hypertransfusion regime. Kalau tak dengar, so hypertransfusion is that we aim for high level of hemoglobin. We aim for 12, the minimum level of hemoglobin. So we transfuse very frequently. So with hypertransfusion regime, you won't see the typical thalassaemic phases anymore. You won't see hypersplenism. You won't see patients with splenomegaly anymore. So this is the problem. And as I have said just now, you won't see thalassemia patient in suspect because we don't have, because in suspect you need to pay for almost everything. So we don't have patients with thalassemia. We don't treat thalassemia patients. Thalassemia patients are handled by HTAA, pediatric and adult as well. But even in HTA, you won't see them in the normal ward. Where you will see them in the daycare. Daycare is where they come for a regular blood transfusion. So sometimes it's a bit difficult for you to see thalassemia patient. But the problem for you at least is that we have so many patients, thalassemia patients on our list. And when do they appear? They usually appear in exam. They appear in your block exam, in your professional exam. I can assure you, 130% you will see thalassemia patients every day. Even our reserve patients are usually thalassemia patients. In professional exam, in block exam, if your exam most likely during PKP, you'll have exam with the sort of modified long case type of exam. So with modified long case are cases that we call from home. And I can assure you the easiest for us to call is actually thalassemia patients because they are very stable, they are cooperative, they have come in exams almost many times per year. So we have their list, they usually come for exam. So the thing is, you will see thalassemia patient when? Master exam. Okay, so that's another thing. The other issue is you and several colleagues of you have mentioned about have shown the photo full blood picture. What I can say is sometimes selalu keluar gambar full blood picture with what is this bite cell just pencil have a look on FBP and actually try and familiarize yourself.
Betul.
Doctor, sorry, we can't hear you now.
Hello. Sorry. When do you want which part my internet? What do you want me to repeat? When did I
The full blood picture, doktor.
Where did I lose? Where did I?
The full blood picture, doktor.
Can you hear me?
Yes. About the full blood picture.
Tak dengar pula.
Hello, doktor. Can you hear me?
Okay, so what I was trying to full blood picture, photos of the full blood picture. Hello? Okay, can you guys hear me?
Yes, betul.
Okay, so what I'm trying to say is full blood picture, the photo of the full blood picture always come in Auschwitz. So we show you some photos of the full blood picture, and then we ask you what are these? What is the diagnosis and so on and so forth. Okay?
Okay, doktor.
Okay, proceed.
Hello, Assalamualaikum.
Okay, hear clearly.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Ikhwan Mizraidi. So I've been given the topic of the disease deficiency and other hemolytic anemia. So I will begin by explaining outline for today's discussion. So we will briefly take a look on the general concept of the hemolytic anemia and also this example. So we know there were many diseases under hemolytic anemia. However, we were only focusing on the DHPD deficiency. And other two examples, okay, hereditary spherocytosis and C ovalocytosis. Okay, so before we further discuss, we have to know what is hemolysis and what is anemia. So hemolysis is premature destruction of the erythrocyte, while anemia is a reduction of the hemoglobin. So from the definition of the hemolytic anemia is a group of anemias of differing etiology. They are all characterized by the abnormal destruction of red cells or increase in the rate of the destruction. So what we would like to highlight here is abnormal destruction of the red cells or increase in the rate of the destruction, which later on bone marrow cannot compensate. So the loss of the blood cell, loss of the blood cell related to the hemolytic anemia. Okay, so next are the classification of the hemolytic anemia, which are the hereditary and acquired. For the hereditary, the first one would be the metabolism or metabolism defect or enzyme deficiency. So the idea behind the enzyme defect is that with absence of enzyme lead to the red blood cell breakdown and lead to the hemolytic anemia. For example, the DHPD deficiency. And the second one would be membrane or structural defects. So these structural defects will make red blood cell lose their cell membrane component. So now because of they are spherical or elliptical, they are unable to pass the splenic microcirculation, which lead to the premature destruction of the red blood cell. For example, hereditary spherocytosis, C ovalocytosis, hereditary elliptocytosis. And last one, we have, and then we have the hemoglobinopathy, which have been explained by the Afiq just now. Okay, next one we go to the acquired hemolytic anemia. So the first one would be the immune antibody mediated hemolytic anemia. For the autoimmune, the antibody is directed against our self-antigens. And for the alloimmune, the antibody attack the donor antigen. For example, in the hemolytic transfusion reaction, alloimmune. So the number one would be the drug-induced hemolysis. For example, the penicillin can lead to the antibody directed against red cell complex that will lead to the hemolysis. And next we have the paroxysmal nocturnal hemoglobinuria or PNH, which is involved in the complement activation against red blood cell. And the number four, we have the red cell fragmentation in the microidiopathic hemolytic anemia or MAHA, where there is a destruction of red blood cell in the abnormal circulation. And last but not least, we have the infection. For example, in the malaria infection, we know there is destruction of the red blood cell intravascularly and extravascularly. Okay, so moving on to the
Presenter, any infection that can cause autoimmune hemolytic anemia?
For example, the infection. I'm not sure, doctor.
Malaria.
No. Atypical infection, such as mycoplasma. So mycoplasma is known to cause autoimmune hemolytic anemia, specifically warm IHA.
Warm IHA.
So mycoplasma, atypical infection. Okay, all right, proceed.
Okay, so moving on to the DHPD deficiency. So DHPD deficiency is the commonest red blood cell enzymopathy. So enzymopathy is the enzyme defect. So it involved in the enzyme in the hexose monophosphate pathway. HMP shunt pathway. So we already know that it is alternative pathway of the glycolysis. Okay, so it's affecting more than 400 million people worldwide, and it is X-linked recessive disorder. So that's why a male will express the condition and the female will be the carrier. And it also involves in the mutation or deletion of the genes locus at the XQ28. And the main races affected would be Africa, Asia, Mediterranean, Middle East, Far East. But what the good thing about the GCPD is that they get protection against the Plasmodium falciparum in the malaria infection. Because we know parasite infect the red blood cell, while in the GCPD deficiency, the red blood cell increase in oxidative stress, so it will give a negative influence to the parasites, the Plasmodium falciparum. Okay, so this is what I mentioned here. Okay, next one in the epidemiology, it is said that GCPD is predominantly in male syndrome. So the prevalence of male GCPD is more, which is 4.6% in Malay, 6% in Chinese, 1.3% in Indians, while it is significantly lower in females at 1.4%, 1.65%, and 0.49 respectively. And a study shown that Orange have higher prevalence of GCPD. So look at the picture on the right. A study has conducted in the Kelantan, Penang, and Selangor. It is proven that the distribution more in male compared to female, and there is high prevalence in orang asal. Okay, so a little bit on the pathophysiology. Okay, I will explain.
Are you presenter?
Yes.
Are you surprised? Are you surprised that it's more in male?
Sorry, doctor?
Are you surprised that GCPD deficiency is more common, is more prevalent in male?
Yes, more common in male, but the female also may occur.
Like, are you surprised?
Support.
Huh? Are you surprised that it's more common in male?
No. I have already know.
So why? Are you going to explain after this? You're going to explain after this, I hope.
Because you know, we GCPD deficiency is inherited in X-linked recessive disorder. So X-linked recessive are more common in the male because we have only one X chromosome, right? And female has two X chromosome. So if the mutation occurs at one X, so the other X will be free from the mutation. So that's why in the female, it will be either carrier or usually unaffected. And if the female can be affected, usually if they have mutation in both copies of the GCPD gene. Is that clear, doctor?
Is there any other way how female can have GCPD as well?
If
other than both parents are GCPD.
If the female the X is normal and the other what we call as the lionization.
Lionization, yes. Lionization.
Yes.
Lionization is actually the name of the lion, is the name of the scientist that discovered this actually.
And also the Turner syndrome, doctor?
Huh?
Turner syndrome.
Yeah, Turner syndrome because dia ada satu X je. Okay, fine, proceed.
Okay, so a little bit on the pathophysiology. I will explain a bit start from the bottom. Okay, to begin with, our body actually produce free radicals. For example, the hydrogen peroxide. So these free radicals can lead to the cell death, including the red blood cell. So that's why we need another molecules in our body, which is the GSH, which is glutathione. this glutathione, which actually act as antioxidant, so that it can neutralize the hydrogen peroxide to the water and oxygen. So this process, we make the glutathione to be oxidized from this to this to become oxidized glutathione. And then we need another enzyme, which is glutathione reductase, to convert the oxidized glutathione to the reduced glutathione, so that it can act as antioxidant. So this process would need the NADPH. So the NADPH will convert it to the NADP plus. And in order to reload the supply of NADPH, we need the G6PD enzyme, which involved in the HMP shunt pathway in the glycolysis, which is the alternative pathway. Okay, so to put it simple, if there is a G6PD deficiency, so there will be reduced NADPH. So there will be reduced level of the reduced glutathione, which is the antioxidant, and the red blood cells are susceptible to damage by free radicals, and it will lead to the hemolysis, which is the premature destruction of the red blood cell. Okay, so actually there are World Health Organization classification G6PD enzyme variants. So it has 5 classes, and G6PD activity is increased following the classes. So this is a general idea about the classification. I will not explain more. Okay, so there are agents that are precipitating the hemolysis in the G6PD deficiency. So there are medication, for example, antimalarials, antibiotics, analgesic, and also the chemical or any illness. Okay, so for example, chemicals like divicins rich in the flavavin. So we have to avoid this kind of precipitating factor. Okay, I would like to touch on the favism. So what is favism? Favism is okay, when we talk about the G6PD deficiency, it is always or usually related to the flavavins. In Malay, we call it kacang parang. So what actually favism is? Favism is acute or severe hemolytic response that occur after ingestion of flavavins. It is believed that flavavin contains divicin, isouremil, and convicin that will lead to the production of the hydrogen peroxide, which is the free radicals. So all individuals with favism have G6PD deficiency, but bear in mind that not all individuals with G6PD deficiency will have favism. Okay, so for the clinical feature of the G6PD deficiency, actually, most individuals are asymptomatic unless triggered by the oxidative stress. As I already mentioned earlier, the precipitating agent, such as the medication, chemicals like flavavin, and any other illness. So at this stage, the patient might develop the hemolytic crisis. So the hemolytic crisis is when there is destruction of the red blood cell in the short period of time that our body cannot compensate. So the patient might come with signs and symptoms of anemia associated with low-grade fever, lethargic, inactive, failure, and other clinical manifestation. The patient might have neonatal jaundice. Okay, for the investigation, we might order investigation during the hemolysis crisis or to detect the enzyme deficiency. During the hemolytic crisis, we order the complete blood picture, function test, and also urine analysis. While in the enzyme deficiency detection, we order the direct enzyme assay on the red blood cell and also fluorescence spot test. So first in the complete blood picture, particularly the full blood count. So it can be normal when there is no hemolysis, but during the hemolysis crisis, the result will be the normochromic normocytic anemia and also reticulocytosis. So while in the blood film, we might appreciate the contracted red blood cell, fragmented red blood cell, white and blister cells, and Heinz body. Second one we do is the liver function test. The result expected would be increase in the unconjugated serum bilirubin due to the increased red blood cell hemolysis. And last one, in the urine analysis. So we might expect increase the urobilinogen, or in severe cases, hemoglobinuria. So this I have provided if you can appreciate the bite and blister cells in the peripheral smear, and also the presence of the Hens body on the supravital staining. Actually, Hens body is actually precipitation of the oxidized hemoglobin. And
these 3 photos always come in OSCE many times already.
this photo
Many times. Tak lah exactly this photo, tapi lebih kurang macam ni lah rupa dia. So always come in exam. Always come in exam. Because it should be easy lah kan. Kalau you pernah tengok ni, I suppose there's no way you should be able to forget lah kan.
InsyaAllah, Doctor. Okay, so for the enzyme deficiency detection, remember we have two. Okay, because of higher enzyme level in the young cell, it will give normal result during the acute hemolysis crisis. So that's why we should do the test for few months, 2 to 3 months. Next is the fluorescence spot test. Okay, actually, the fluorescence spot test is based on the principle that the NADPH. So remember, the NADPH is generated when there is NADPH generated is the fluorescence, meaning that. So meaning that if there is normal DHPD enzyme activity, so under UV light it will produce fluorescence. So if decrease or no activity of DHPD enzyme, it will display weak or no fluorescence. So this I have provide example finding in the fluorescence spot test. For the first line, this is a normal DHPD enzyme, so it will give strong fluorescence because of the NADPH and under UV light. And if there is deficient or less DHPD activity, so it will give less or no fluorescence under UV light. For the treatment, mainly it is supportive. So what we could do is to stop the offending drug, the precipitating agent I've mentioned earlier, treat underlying infection, and we can give blood transfusion if necessary, and also DHPD deficiency babies prone to get the neonatal jaundice. So medication based on the severity, and if there is a severe anemia, the blood transfusion might if necessary. And a little bit on the membrane defect, there are two. The most important one is the hereditary spherocytosis. Okay, so the hereditary spherocytosis is the most common inherited red cell membrane defect. The hereditary spherocytosis can be autosomal dominant and recessive, but typically it is autosomal dominant trait, and it occurs worldwide with an unknown rate of the incidence, and it is characterized by the increase in the osmotic fragility. So the red cell is typically fragile. So therefore, if you run the osmotic fragility test, it will show that the osmotic fragility is increased, and also we spirolytic red cell in the peripheral gut. And a little bit on the pathophysiology in the hereditary spherocytosis. So the defect in the protein complex in the vertical interaction leads to the membrane defect. So when we talk about the vertical interaction, we are referring to the protein such as protein spectrin ankyrin complex, Bentry protein, and also the pallidin protein 4.2. So it is either due to the deficiency or functional abnormalities, but normally due to the protein deficiency. Okay, so when any of one of them has been defect, so part of the lipid bilayer is not supported. So destabilization of the lipid bilayer. So when when the red blood cell start circulate in the circulation, the red blood cell can lose part of the membrane and become spherocytes instead of a normal red blood cell by concave. So this spherocyte form, it will easily to trap in the microcirculation, in the splenic circulation. So it will taken up by the cells of the reticuloendothelial system, where they are eaten by the macrophage and prematurely destroyed. So it is destroyed in the macrophage in the reticuloendothelial system. So the hemolysis is the extravascular hemolysis. What are the clinical features in the hereditary spherocytosis? They may present in the anemia, may present at any age, depends on the severity and mutation. Okay, so since it is hemolysis, they present with a jaundice. Splenomegaly mainly because in the chronic hemolysis, the spleen would be site of the red cell destruction, so therefore it will enlarge. And as in other hemolytic anemia, it may present later with gallstones, the pigmented type. And full blood count show reticulocytosis, and it is prone to risk for the aplastic crisis, because in aplastic crisis they usually present in the remember apa tu Amina have explained, aplastic they usually present with the pancytopenia. So imagine if the patient have any hemolytic anemia but may actually complicated with the aplastic crisis, especially when there is superimposed of the parvovirus infection. And typical blood film in hereditary spherocytosis is microspherocytes in the peripheral blood film with classic finding in the osmotic fragility test. So this is the osmotic fragility test to confirm the diagnosis of the hereditary spherocytosis. So the curve is shifted to the right, indicating that the red cell is lysed even at lower concentration of the sodium chloride. So the blood film I told you just now, the presence of the microspherocytes. So they are the rounded red cell, kind of smaller red cell. And also a little bit on the C ovalocytosis. So Southeast Southern East Asia ovalocytosis is a rare inherited hemolytic anemia, but common in Southeast Asian countries such as Melanesia, Malaysia, Indonesia, and Philippines. It is caused by the Bentry mutation. So remember, the Bentry is part of the vertical interaction of the red cell membrane. So in the heterozygous mutation, usually is mild, and the most cases asymptomatic and not anemic, while in the homozygous mutation, it can be lethal. And the cells very rigid and resist invasion by the malarial parasites, as I mentioned earlier. And the typical blood film in this, the red cells are oval erythrocytosis with a bar across the central film. Okay, that's all from me.
Okay, all right. GCSPD is another topic that always come in the exam as well, but usually probably I would say previously it comes in PMP, so you guys don't have PMP anymore. So yeah, I think MCQ lah kalau tak. But the GCPD is very common lah. GCPD is very common. I myself GCPD deficient. Alright, fine, proceed. How many more presentation?
One more, Doctor.
One more, finally. Okay, let's go to the last. Nanti, please, I need everyone to email me your presentation, email or WhatsApp me your presentation.
Okay, Doctor. Okay, can you hear me?
Yes.
Yes. Okay. Assalamualaikum warahmatullahi wabarakatuh. So I am Nur Nabila binti Zahri, metric number 1810790. I will be the last presenter for today's seminar. I hope you guys are still doing good. Okay, so my topic is immune thrombocytopenic purpura. So these are my contents for today's seminar. And what is ITP? So ITP is ITP is a diagnosis of exclusion, and it is previously known as idiopathic thrombocytopenic purpura. And acute childhood ITP is a benign self-limiting disorder presenting with isolated thrombocytopenia with a normal blood count, absence of underlying cause. 5% of patients with acute ITP may have recurrence of acute ITP, and chronic ITP can develop in 10% of patients with acute ITP. So these are the classification of ITP. We classify ITP into primary and secondary. Primary is ITP without underlying cause. Secondary is ITP with an underlying cause. As for primary ITP, it is subdivided into the 3 phases, which is a newly diagnosed ITP, which is ITP within 3 months from the diagnosis, persistent ITP, which is ITP between 3 to 12 months, and chronic ITP is considered when ITP lasts for more than 6 months. So I will talk about chronic ITP later. So these are the secondary ITP, the common causes of thrombocytopenia. Okay, so these are the epidemiology. ITP is a commonest cause of thrombocytopenia in childhood. So majority of children with ITP will have a history of preceding viral illness, and 1.9 to 6.4 per 100,000 children per year was reported with ITP cases. And ITP will actually affect boys and girls, but chronic ITP is more common in female. Children with ITP can present at any age, but the peak age for ITP is 2 to 10 years old, and 50 to 65% of cases of childhood ITP was reported. So the pathogenesis of ITP. So ITP is an autoimmune disorder characterized by autoantibody mediated immunologic destruction of normal platelets. So this mainly occurring in the spleen. This is in response to an unknown stimulus. And autoantibodies, typically IgG, but sometimes IgM, are directed against platelet membrane antigen, which is such as glycoprotein to B3A complex. So after the binding of the antibody to the platelet surface, the circulating antibody-coated platelets are then recognized by the FC receptor on splenic macrophages. Then it will be ingested and destroyed. So this will result in reduced platelet counts, accompanied by increase of megakaryocytes, which is a platelet precursors. So the clinical manifestation of ITP, onset of ITP is usually abrupt or acute, and majority of patients we have a history of viral infection in the preceding 2 to 4 weeks. The duration from the onset of patient to have thrombocytopenia to platelet to become normal is few days to 6 months. Average is 3 weeks. So usually thrombocytopenia is diagnosed incidentally during routine full blood count. So the symptoms, patient can have a history of fever, bleeding tendencies, mucosa bleeding, epistaxis, parietal bleeding, hematomesis, or even hematuria. The signs of ITPs, such as petechiae and purpura, as well as superficial bruising that will lead to ecchymosis. Children with ITP will not have organomegaly or lymphadenopathy. And intracranial bleeding is a rare complication of ITP, which occurs about 0.1 to 0.5% of the cases. So the bleeding severity of ITP can range from cutaneous bleeding to mucosal bleeds and to a life-threatening bleeds, which is intracranial hemorrhage. So this is the most serious clinical manifestation or complication of ITP. So when patients present with the signs and symptoms of ICH, such as seizure, headache, altered mental status. So immediate evaluation is needed for that particular patient. So these are petechiae and purpura. Petechiae is a pinpoint non-blanching spot. Purpura is bigger than petechiae. So this is gum bleeding. Complication of ITP is intracranial hemorrhage. It is the most feared complication of ITP, which occurs between 0.1 to 0.5% of the cases of ITP. Quite rare, but the risk is highest with platelet count of less than 20 times 10 to the power of 9 per liter. And when patients have a history of head trauma, also a use of antiplatelet medication such as aspirin. So these are the differential diagnosis of ITP. Again, ITP is a diagnosis of exclusion. So we need to exclude other causes of thrombocytopenia first before we can diagnose patient to have ITP. So examples of differential diagnosis, hematological malignancy such as acute lymphoblastic leukemia or ALL can also present with thrombocytopenia. But ALL will have other clinical and laboratory findings that will differentiate it from ITP, such as presence of hepatosplenomegaly. And thrombocytopenia in ALL in ITP is more severe than ALL. Active infection, the ongoing viral infections such as Epstein-Barr virus, cytomegalovirus, Hep C, and HIV-1 can also present with thrombocytopenia. Autoimmune disorders such as Evans syndrome and SLE can also present with thrombocytopenia. Evans syndrome is an autoimmune hemolytic anemia that occurs in combination with thrombocytopenia. Primary immunodeficiency syndrome, such as Wiskott-Aldrich syndrome. Drug-induced thrombocytopenia is rare, but can present with thrombocytopenia. Examples of the drug is heparin, which is an anticoagulant. So the diagnosis and investigations of ITP. So we diagnose ITP based on history, physical examinations, blood counts, and peripheral blood film. So as for physical examinations, there will be absence of hepatosplenomegaly or lymphadenopathy, and the full blood count will appear normal, except that patient will have a thrombocytopenia. And peripheral blood film will also appear normal, but patient will have a reduced amount of platelet and increased size of platelet, but there will be no abnormal cells detected in the peripheral blood film. The coagulation profile, patient will have a prolonged bleeding time. These are the other tests that may be indicated when there is an atypical presentation. So bone marrow aspiration is not necessary if the physician is certain that the diagnosis has, if the personal history, family history, physical examination, full blood count, and full blood picture are typical of ITP. However, it is indicated if there is a presence of atypical features such as organomegaly, significant lymphadenopathy, and also abnormal blood count or suspicious peripheral blood picture. And bone marrow aspiration is also indicated before starting steroid therapy, and also when patient is not responding to intravenous immunoglobulin therapy, and when patient have a persistent thrombocytopenia beyond 6 months, and thrombocytopenia recurs after initial response to treatment, meaning that meaning that patient has a loss of response to the therapy that works initially. So the management of acute ITP. So most children remit spontaneously, meaning that the platelet count will resolve spontaneously if given enough time. So not all children with acute ITP will need hospitalization. The hospitalization criteria is when patient have a severe life-threatening bleeding, in example, intracranial hemorrhage, regardless of their platelet count, and also when platelet count is less than 20 times 10 to the power of 9 per liter with evidence of bleeding, or when platelet count is less than 20 times 10 to the power of 9 liter without bleeding, but patient is inaccessible to healthcare. And when parents itself request for admission because they have lack of confidence to take care of their children at home. We have to advise patients to take extra precaution with physical activities, especially small children, and also to avoid any contact sports and to seek immediate medical attention if there is a significant bleed, and to avoid aspirin or NSAIDs. These are antiplatelet that can increase the risk of ITP. So treatment, in general, it is indicated if there is a life-threatening bleeding episode, regardless of patient's platelet count, and also platelet count of less than 20 times 10 to the power of 9 liter with presence of mucosal bleeding, and also platelet count of less than 10 times 10 to the power of 9 liter with any bleeding. So the choice of treatment is to give oral prednisolone or intravenous immunoglobulin for a single dose. Emergency treatment, it is usually indicated in intracranial hemorrhage patient. We give high-dose intravenous methylprednisolone and also intravenous immunoglobulin. A combination of intravenous immunoglobulin and methylprednisolone in life-threatening condition. And we have to consider a platelet transfusion in any life-threatening hemorrhage. The physician should also consider emergency splenectomy if other modalities fail. But emergency splenectomy is... Yes, doctor.
My question is, why we only transfuse platelet only in life threatening? Why don't we just transfuse in because the problem is low platelet, isn't it?
Yes.
So why don't we transfuse all? Why only life threatening?
Because in acute ITP, they will resolve spontaneously. I mean, the platelet count will become normal if given enough time.
Other than that, if it's very, very low but not life threatening, why don't you?
I'm not sure, doctor.
What's the pathophysiology of ITP?
Platelet destruction.
Yes, but why? It's immune mediated, isn't it? It's immune mediated. So your antibody, there's auto antibody attacking platelet. So if you transfuse platelet, what do you expect? What do you expect to happen?
Platelet will not resolve. I mean.
So if you transfuse platelet, then the
antibody will attack platelet.
Transfuse. So there'll be more antibody formation. So finally, you always transfuse out of again because you produce antibody against all types of platelet. Because the problem is antibody is mediated. So the more it's used, the more immunological response. So the more antibody formed. That's the idea. And then remember, with blood transfusion, all have risk of infection and so on and so forth, hepatitis B, HIV, so on and so forth. So even with platelet transfusion, there is that risk as well.
All right. Thank you, doctor. Can I proceed?
Okay, all right.
Okay.
Proceed. Yes, proceed.
So let's move on to chronic ITP. So what is chronic ITP? Chronic ITP is the persistent thrombocytopenia after 6 months of onset, and it occurs in 20% of patients. So it has a wide spectrum of manifestation from mild asymptomatic low platelet counts to an intermittent relapsing symptomatic thrombocytopenia and to a rare persistent symptomatic and hemorrhagic disease. So the management of chronic ITP are divided into non-medical and medical management. As for non-medical, we give counseling and education of patients and their caretakers regarding the natural history of the disease and how to detect the problems and possible complications. So parents should also aware on how to seek immediate medical treatment when the need arises. So every opportunity should be given for the disease to remit spontaneously. And asymptomatic children can be left without therapy and kept under observation with continued precautions during physical activity. We have to always revisit diagnosis to exclude other causes of thrombocytopenia. As for As
Sorry,
for, as for
one
medical
thing.
management,
Wait. One thing to remind about counselling. You need to remember school as well. So one not mistake lah. We did right the school. It wasn't clear enough. So what happened in children? They have this regular dentist that come and do assessment and treatment in children. So we've returned to the school. But we've mentioned only about physical activity. Mentioned about surgical and dental procedures. So one patient had undergone tooth extraction. So luckily the bleeding stopped. It was a delay, but the bleeding wasn't massive enough. But because all is remaining, the patient already had, and all the platelet is being used to stop the bleeding due to extraction. So finally, the patient with left was very some hemorrhagic bleeding, cerebral hemorrhage. Patient developed stroke just because of that. So you need to remember proper counseling, not just caretaker, parents, also school, and it must be very, very clear and explicit.
Okay. All right. Thank you, Doctor. Okay, as for medical management, symptomatic children may need a short course of treatment, and the second-line therapy such as steroid pulses, intermittent anti-RHD immunoglobulin can be given for chronic ITP patient. But rituximab and cyclosporine may be considered in refractory disease. So splenectomy is rarely indicated in children as spontaneous remission may still occur up to 15 years from the diagnosis. Why it is rarely indicated? Because the risk of dying from ITP is much lower than the risk of dying with post-splenectomy sepsis, which is 1.4 to 2.7%. Okay. But splenectomy may be considered if there is a life-threatening bleeding event or there is a severe lifestyle restriction with no or transient success with intermittent intravenous immunoglobulin, steroids or NTD immunoglobulin. So this is the table to differentiate acute and chronic ITP. Acute ITP is more common in childhood, but chronic ITP is common in adulthood. And as for acute ITP, there is no sex preference, so it can affect equally both male and female. But chronic ITP is more common in female compared to male. And the degree of thrombocytopenia in acute ITP is severe compared to chronic ITP, which is just moderate. And in acute ITP, spontaneous remission usually occur, but in chronic ITP, usually patient will need therapy. The duration for acute ITP is 1 to 6 months. Chronic ITP can occur months to a year. The prognosis of acute ITP is very good, but chronic ITP is fair. So last but not least, the prognosis of ITP. Children, more than 80% of children with untreated immune thrombocytopenia will have a spontaneous recovery with completely normal platelet counts in 2 to 8 weeks, and fetal bleeding can occur in 0.9% upon initial presentation. As for adult, approximately 60 to 90% of adults with ITP respond with an increased platelet count after treated with prednisone and intravenous rhesus immunoglobulin or intravenous immunoglobulin alone. Adults who require splenectomy, approximately 2/3 of them have a sustained response and 10 to 15% have a partial response. So these are my references, and thank you.
Okay, all right, proceed. Okay, any question to the presenter, not to me, to the presenter. Any question? So ITP is very common as well to come in exam. Obviously, you won't see any ITP case in your clinical exam unless for, you guys are in the new curriculum, isn't it? So new curriculum, one thing probably in communication station, so we can ask for communication. We can present the mother with a child who's newly diagnosed as ITP. So it's up to you to counsel. So these are among the questions that I think would be interesting to ask for your modified, not modified, or your man or ski. So man or ski are the communication station. So you can expect this sort of patient. We can bring patients with a mother whose child just diagnosed as DKA due to type 1 diabetes mellitus or ITP. So how would you counsel? So these are our favorite questions to ask in the exam. Okay. Any other questions? Ke semua dah exhausted dah. Dah buat cetong lah ke?
Doctor, sorry. Okay,
Yes.
Okay, actually, can you please repeat again regarding the acute management in ITP? We can't hear you clearly just now before. Well, first, it was because of high risk infection, and the other one? No, doctor.
Oh, so the when transfusion is it?
Yeah, in acute ITP we don't give platelets, right?
So why we don't transfuse is basically first is because the pathophysiology of ITP is because of it's immune mediated. There's antibody against platelet. So if you transfuse platelet, whatever donated platelet, there will be antibody going against it. Faham tak? So that's why the only reason why you give is only when it's life-threatening. If it's not because life-threatening, you just need to save the life for that particular moment. Because if you have time, you'll give the other methylprednisolone or IVIG or other things. You only give it for life-threatening. Because the problem is immune mediated. There's antibody against platelet. The more platelet you give, more antibody will be formed against any other platelet that you're going to give. So that's the reason why we don't give. We only give platelet transfusion only for cases of life-threatening, just for that particular moment to save life. And blood transfusion, including platelet, has lots of complications as well. Infection, among others, fluid overload, among others. Okay, clear?
Okay. Another thing is, can I ask one more?
Yes.
Regarding the previous presentation on thalassemia, you said something about hydrops fetalis. That one also I'm not clear.
What I was trying to say is hydrops fetalis actually means hydrops fetalis actually means heart failure in a fetus. A fetus with heart failure. That is hydrops fetalis. So it does not just caused by alpha thalassemia. There's many other causes for hydrops fetalis. So any babies that is born with two organs that is fluid overloaded, you'll see ascites, you'll see pleural effusion, you'll see pericardial effusion, you'll see generalized anasarca. So all these are signs of hydrops fetalis. So hydrops fetalis just means a fetus with heart failure. Faham?
Okay, faham. Thank you.
Okay, all right. Any other question? Okay, tak ada question. Clear? Semua faham dah? 2 hours semua dah pun exhausted dah. Okay lah I think that should be okay lah if there's any other question, you guys can ask me later or you can WhatsApp me lah, insyaAllah. Okay, let's end our session with tasbih kafarah surah As. So please email or WhatsApp me your slides, yeah? Okay, alright. I won't give marks if you don't email me. Okay.
Thank you, Doctor.
Okay,
Okay, Doctor.
Salam, thank you, Doctor.
Ya,